Okay, here we are with a very special guest. Um, Someone who really holds a unique um, position in our field. Dr. Benjamin Natelson is a neurologist, and we don't, and neurologists, at least anecdotally, from what I've been told, really do have not embraced ME/CFS or these diseases for a long time. And Dr. Natelson embraced them very early on. In fact, Dr. Natelson has written several books on ME/CFS. He has a huge research background. He's been studying ME/CFS and fibromyalgia and now long COVID. For many years, he's one of the few researchers that that has been pretty consistently been able to get NIH grants, and he just snagged a bunch of them. And he runs the Pain and Fatigue Study Center at Mount Sinai. He's a researcher, he's a doctor, he's an author, he's every man. So it's great to speak to you, Dr. Natelson. Thank you very much.
Well, thank you for letting me meet you face to face and talk to you and your audience.
Oh, thank you. Yes, absolutely. It's an honor. But I want to really ask, given that you are a neurologist, how did you come to embrace this field so long ago? Really, when it was in its dark days, with regards to public and research and medical acceptance.
Right.
And yeah.
Well, that's a great story. I was at the Rutgers Medical School. It was called the University of Medicine and Dentistry of New Jersey in those days. And we doctors were allowed to keep a very small private practice in addition to our academic position and salary. And I was at the point where my small private practice had to change. And so my chairman told me that Jim Oleski, a pediatric immunologist at the medical school, had been seeing patients with chronic fatigue, but he had to give up that practice because he got involved in pediatric AIDS. And he was overwhelmed at that time. It was the late 80s. And so he said to me, here's a practice. And he just handed me his patients. And I started seeing these CFS patients in 88. 88. And
Wow.
I said to myself, there is something going on with these patients. Let me start collecting some medical data on them. So over the next 2 years, as I saw patients, I got information about immune functioning, about functional status, a whole bunch of stuff. And I wrote a bunch of papers in the late 80s, early 90s, just at the time that the NIH announced that it was going to set up CFS centers of excellence. So I applied for one, and no one in the CFS community in the early 90s had ever heard of me because I just published these 1 or 2 papers, and everyone was flabbergasted because I got one. And I had that center from 1990 or 91 until NIAID decided that CFS was neither infectious nor immunological and said, we don't want to fund these centers anymore in 2004. So that's how I started. Jim Oleski gave me these patients, small number of patients, and then more and more came. And now that's all I see. I moved to Mount Sinai, I guess, 2004, and I've been there ever since. And I've been lucky. Mount Sinai was way better than the Rutgers Medical School because it's full of people way smarter than me. And I love to be surrounded by smart people. So let me tell you what that translates into. we now have a couple of studies that are ongoing that are funded by NIH. One of them that we really need to get patients for. Now, I have to say, Court, that these studies require people to be within 50, 60 miles of Upper Manhattan because they have to come in. So the one study we're doing that just started July 1st is we are comparing the brain images of chronic fatigue syndrome patients to patients who have their CFS following COVID. So I call it long COVID CFS and not long COVID CFS. And we are doing imaging studies in both groups of patients and paying our research subjects a modest amount to participate. And the other study we are doing is there has been some information in the medical literature that a physical exercise scientist can learn about post-exertional malaise by doing stress tests.
Yes.
And that's happening now in Albany and somewhere on the West Coast. And we wrote an NIH grant. I did it in association with probably one of the most brilliant exercise cardiologists in America, Donna Mancini. And she and I are doing the following thing. We give a CFS patient a wrist-mounted computer that they wear for 8 days to tell us about how they are feeling symptom-wise before we do the stress tests. And then they come in and we do 2 stress tests a day apart, and they continue wearing the wrist-mounted computer for another 8 days, because that's going to let us look at how they did in the stress tests and whether or not they got PEM. Because we now can see PEM because they're telling us on this wrist-mounted computer how they feel before and after the stress tests. And we also can see how active they are before and after the stress tests. So that's a study we really need ME/CFS patients and their healthy relatives who do not exercise regularly. All our healthy controls are sedentary, because if you study a person who's active and an athlete, being in very good shape changes a lot of biology and can produce an effect just due to fitness. So we use sedentary controls. So if anyone in your audience has ME/CFS, lives within about 50, 60 miles of New York, we can pay for an overnight hotel. We would love them to be involved in our study. And the way they contact us is either 212-844-6665 or pain and fatigue, spelled out, at Mount Sinai, spelled out, MOUNTSINAI.org. That gets any query into my research team's hands, and we are very, very anxious to study ME/CFS patients in the imaging study and in the PEM study. We are doing a couple of things also in long COVID. The first long COVID study is if the patient has CFS, we're comparing how his or her images, brain images, compared to those of patients whose CFS is not due to COVID. And that's producing some very interesting results. And the other thing we have determined is both our long COVID and our CFS patients, some of them have a breathing abnormality, but we only can pick up the breathing abnormality if we ask the patient to do an exercise test. So we're bringing these long COVID patients in for an exercise test. And if they have this breathing abnormality, which we are going to understand and then treat, because one of the abnormalities we know that some of our patients have, both the long COVID and this ME/CFS, is they overbreathe. They hyperventilate unbeknownst to them, and that adds to their fatigue and pain. And so we need to identify them, and we're coming up with a way to treat that. And there is another breathing abnormality that we're finding in both sets, the long COVID CFS and the not long COVID CFS, that we need to study. So our research is imaging long COVID CFS with ME/CFS, not long COVID, post-exertional malaise. We do 2 exercise tests a day apart. And then we're also doing exercise testing in long COVID to look for this breathing abnormality. So that's the major research in the lab right now, Court.
You found an unusual breathing abnormality in ME/CFS before. And is this the same breathing abnormality? And could you explain what you found?
Yeah. So there are 2, and we're finding this in both our cohorts of ME/CFS, the long COVID related and the non-long COVID related. There's one group, and there's first I'll talk about both, and then I'll tell you they overlap. One set of patients, about a quarter, are overbreathing, unbeknownst to them. They're not, actively anxious. Anxiety causes overbreathing, but they're not real anxious, but they do have this overbreathing.
Can I ask you?
Sure.
Does that mean that they're breathing too deeply, or they're breathing too quickly, or
too
both?
deeply? Usually it's so they're not panting like a puppy.
Yeah.
Unbeknownst to them, they're breathing too deeply. And we hear that, and I can check that 2 ways. I ask them to close their ears like I'm doing now and tell me if they can hear themselves breathe without changing the way they breathe, because you shouldn't be able to hear yourself breathe. So if they do, that suggests they're moving too much air. And the other is a symptom. If they yawn or sigh a lot, that's another symptom of overbreathing. So that's the first. It's this overbreathing, and it's not fast breathing. It's deeper breathing than is normal. So I'll just tell you how this happens. When we eat food, the byproducts of food are water and carbon dioxide. And the carbon dioxide goes through the bloodstream to be exhaled by the lungs. And that's pretty normal. If you have lung disease, which is called COPD, chronic obstructive pulmonary disease, then you can't blow off your CO2, and your CO2 goes up and up and up. And that's what causes illness and lethality in COPD, inability to exhale your CO2. But then there are individuals who are moving too much CO2 out of their lungs. They're sort of, if you will, overbreathing or hyperventilating, and this reduces the blood level of CO2 and adds a second burden to the ME/CFS. And we can treat that with biofeedback.
Biofeedback. Okay. Do you know why? I believe you found that in Dane Cook's study. Was that what you found in Dane Cook's study? This unusual breathing pattern? I think you were part of that.
No, I was, but that's the other thing
during
we
exercise?
reported. The other thing we reported in our long COVID paper that we published a couple of years ago is that, so I said about a quarter of the patients are overbreathing. Another quarter of the patients have this funny sighing like breathing when they do the exercise. So usually when you exercise, your the amount of air you move should gradually move up the way I'm showing you with my hand. But
Right,
what
right.
happens in these patients is it goes up and down. It's sort of sighing breathing, and that's abnormal. So we have in our in our long COVID CFS and our non-long COVID CFS, we find patients who just overbreathe, patients who just have this odd dysfunctional breathing, and patients that have both. So we don't really know what either is caused by, and we're working on that. That's one of the reasons we're doing the stress test to try to understand who gets these breathing abnormalities and where do they come from, because we don't know that.
Is that why I saw that in one of the studies, in the brain imaging study, you're looking at the brainstem. Is that do you think it could come from the brainstem or
Well,
some
breathing,
autonomic
I
nervous
mean,
system
if
problem?
there's, yeah, I mean, it's certainly possible that overbreathing could be brain related, but we just don't know. I mean, I don't even know where to start. I mean, overbreathing is thought to be lung related. If you have trouble with your the vessels to your lung, uh, you overbreathe. If you have asthma, you overbreathe. But none of my ME/CFS patients have anything wrong with their lung, and they don't have asthma. So we're really at back at zero to understand it. So the first thing we're trying to figure out is who gets it, what's the characteristics of the patient who get it. And again, we're studying this in both non long COVID CFS and COVID related CFS.
I noticed that um, in that study that you're particularly focusing on the cerebrum and the brainstem. Can you explain why you chose to focus on these areas?
Well, actually, we backed up. We're really in our new studies court. We're really looking at the whole brain because my colleagues figured out a way to measure oxygen in the brain and glucose utilization. So we're going to understand the metabolic response of the brain in ME/CFS. Some people have looked at the brainstem, but that's hard to image. So we're not sure about that. We're talking about it, but we haven't focused on that yet. Right now, our studies are looking at oxygen uptake and glucose usage in the brain.
Will you be you'll be looking to see if the brain has normal oxygen uptake and glucose utilization. Will you be looking to see if it's receiving normal amounts of oxygen, or is
Well, we
this
know we know it is. I mean,
okay?
we know it is unless you have a blockage to an artery. We know what I mean. We can do that finger thingy where that tells you how much oxygen is in your bloodstream.
Mhm.
So we know how much oxygen is in the bloodstream, and we know how much oxygen is taken up by the brain. So we'll determine whether the brain of the CFS patient uses oxygen and glucose the same way as a healthy control. That's what that study is going to show us.
Got it. Got it. And I guess has anybody done that before? Tried to do that
No,
before?
we've done a little bit of work on oxygen uh, that led my colleague. I have a brilliant imaging colleague. Her name is Dr. Zhang Zhu.
Uh-huh.
She's came from Hopkins, and she's just, I can't tell you how smart she is. And she just got a big NIH grant that started July 1st to compare our two cohorts and to add, she'd been looking at oxygen, and now she's going to add glucose.
Oh, great. Great.
So we're excited by that study. So, and that study, We do reimburse our subjects, our healthy subjects, and our CFS patients for participating in our imaging and in our exercise testing for PEM.
Great, great, great. Now, I see in the cardiovascular analysis of post-exertional malaise that one thing that you're looking at is reduced blood volume,
We
uh,
are.
which is, it's a fascinating subject but it just doesn't really. I've always wondered why we haven't had more research on that, given that it could play a major role.
Well, one of the things that drove it is I'm interested. The 2015 case definition for CFS added orthostatic intolerance as one of the possible symptoms that leads to the diagnosis. What's orthostatic intolerance? Well, it's when a patient says that when I'm standing on my feet, not moving, I feel worse than when I move. And then the biological representation of that, which is what I need more than just the self-report, is that the heart rate goes up or the depth of breathing goes up and they start hyperventilating. So the first one is called orthostatic tachycardia. And let me tell you the biology. When a person rests, and chronic fatigue syndrome makes people rest, NASA uses bed rest to emulate life in space, because when you're at bed rest, your body changes the same way as if you're in space. And what happens when you're in space is your heart gets smaller, your heart's ability to work gets less, and your blood volume goes down. So what happens, and this is very, very common in young people who are actually healthy, is when they stand up, they go from lying to standing, they move a pint of blood from their thorax, from their middle, into their legs. And when they stand up, and this is what happens to an ME/CFS patient with POTS, their chest and heart says, where's the blood? And it doesn't find the blood, so it makes the heart beat faster to get more blood to the brain. And that's called orthostatic tachycardia. We have added assessment of breathing to our orthostatic challenge and find that patients often have this gravitationally related overbreathing. They're breathing just fine when they're lying, but when they're up, they overbreathe. And that overbreathing can turn on the heart rate. So overbreathing is probably the first abnormality, and then rapid heart rate is the second. And
so it's a compensatory. It's trying to compensate.
That's right. So we thought that the cause of that, everyone talks about dysautonomia in ME/CFS, but I always thought, gee, the first cause is probably because they're forced to rest by their disease, that their blood volume has gotten low, so that when they do a tilt test or a lean test, and they move that pint of blood into their legs, their chest doesn't have enough blood, and so they overbreathe and they develop a fast heart rate. And so that's why we wanted to measure blood volume, because we expect that low blood volume is going to be seen in POTS. We're not finding that all the time, I have to say. I thought we were going to find it all the time. We're not finding it all the time, but we are finding it in some patients. But that's why we wanted to see how blood volume, what role blood volume plays in a patient's ability to do an exercise test. So we've got that, Court, and we're going to start looking at those data in the new year.
Oh, good. Do you have any data on their level of fitness or activity?
Of what, Court?
of how much activity they're engaged in. I mean, I would be an interesting test case because I I was deconditioned early. I'm pretty sure I was deconditioned early in my illness when I was really severe. And I don't know if anything could have set in then, but I'm not deconditioned now, and I just wonder how I would fare under those in these tests. I do not
Well,
have POTS either.
so let me ask you,
Yeah.
this is a question I ask every patient I see in my clinical evaluation, and that is, how active a person have you been in the past month? If 100 was, we can't talk, your best friend or significant other, and 0, so ill you can't get out of bed. So what would Court tell me? In the past month, how active have you been?
I'd say I've been probably between 60 and 70. I assess my steps with an Oura ring, and
How
you
many
know,
steps do you do?
well, Oura, or what does it? I probably average. It fluctuates, but I probably average 7,000,
That's fat. See, if
Yeah.
I could get my ME/CFS patients to do 7,000 steps, they'd be better. So what are you not doing that you ordinarily would do activity wise?
Well, activity wise, the difference now is that it's basically slow walking.
Yeah,
I just walk. I to give my dogs. I want to give my dogs a walk. So
sure.
my heart rate. I'm not pushing it. Um,
Exactly.
yeah,
And that's what I call gentle physical conditioning.
yeah.
So I want to tell your audience about this book that's now ancient, but it's all the same. Your symptoms are real. What to do when your doctor says nothing is wrong. It's an old book, but the chapter I have on walking, uh, that's so important. That's the best and least prescribed treatment for ME/CFS is gentle physical, not exercise, but
No.
gentle physical walking. It's great.
Yeah, yeah. I mean, hiking is. But I'll say what I have found is that uh, using light exercise with exercise bands and uh, and small weights is surprisingly helpful in a kind of subtle way. Uh,
I hear
yeah,
you.
yeah. And it actually helps with my orthostatic intolerance a little bit as well.
Well, let
It's
me
kind of
tell you
interesting.
how
Yeah,
I let me
yeah.
tell you how I treat orthostatic intolerance. The first thing is I do a lean test. And a
Mhm.
lean test is, you can do this yourself. You hook yourself up to a blood pressure cuff that uh, someone has to write these numbers down. So you can't be completely alone. Otherwise, unless the blood pressure cuff can remember. And you lie flat on your back for a good solid 10 minutes. And then you measure your blood pressure and heart rate every minute for 3 minutes to make sure it's stable. That's lying flat supine. And then you stand up and lean against the wall with your shoulders. Your feet are about 6 inches away from the wall. That's it. Nothing else touches but your shoulders and your arms at your side. Your legs are together, and you do the blood pressure and heart rate every minute for the next 10 minutes. That is a poor man's tilt test. And it's good, it's accurate.
You found it
So
accurate. Yeah.
that, and some people who have no trouble standing say, oh God, that lean test, it was murder. So we have to see, but that will tell me if their heart rate goes up. Doesn't tell me anything about breathing. That for breathing, you need to be able to have the patient face to face so you can really assess the breathing. But it does tell you about heart rate and POTS. And then the treatments I use, the first treatments are oral rehydrating salts.
Mm.
That is, you can buy those on Amazon. They're called trioral rehydrating salts. And they use them The man who invented their use for dysentery just died last week. And if you can take a quart of these a day, and then I also recommend compression tights so the blood doesn't pool in your legs. And it can't be just knee socks, compression knee socks, because those act like tourniquets. So the tights have to go, I mean, the compression garb has to go from your ankle to your waist. And those two things, the tri-oral rehydrating salts and the compression hose, help a lot of patients. They don't need any medicine. And then if they still have a marked increase in their heart rate, then I turn to drugs.
Right, right. Do we have any idea why there's this blood pooling in the abdomen or the legs? Why some people experience this?
You mean when they go from lying to stand?
They stand up. What
Well,
is
first
going
of
on
all, some
down
of it's,
there?
let me make the point that some of it's normal. When you go
Yeah,
from
yeah.
lying to standing, you shift your blood so it goes to the lower abdomen and the legs. And that's why the compression hose, and also the third thing I use is an abdominal binder to prevent blood from pooling in the lower abdomen around the organs there. Those things often help. They often help orthostatic intolerance. And if they don't, I need to get someone in for a formal lean test and see if they're over breathing during the lean test, because you can't determine that with blood pressure and heart rate.
And if they are overbreathing, you can use biofeedback to
We can.
kind of retrain the system. Can you kind of like reset it so that people are breathing normally?
What we do is that we found a device. Now, the devices that measure exhaled carbon dioxide in the American medical field are expensive. But there's one company that exports from China. It's called Contech Health, CONTEC health.com.
Okay.
And they make a capnograph that only costs $250. Now, with this capnograph, you can hook yourself up and see how you're breathing. It'll tell you how often you're breathing. So if you're breathing faster than 15 breaths a minute, that's too fast. So then we slow you down. That's the first thing we do. We slow your rate down. And then the next thing we do is you use the capnograph, which is telling you where your exhaled carbon dioxide is. And if it's low, then the goal is to raise it up. And the patient can just sit in front of the capnograph and do whatever maneuver he or she wants to try to raise that number up. That's biofeedback.
Do patients often feel better when they see the?
It's very hard for me. The answer is that if they can defeat their overbreathing and raise their exhaled carbon dioxide to normal levels, which is 35 or higher, they feel better. Yes, for
Got it.
sure.
Got
And
it.
so I recommend, now that I found this cheap, very cheap Chinese machine that measured exhaled carbon dioxide, contechhealth.com, I tell patients, buy it and sit in front of it, look at and then we talk about, I tell them what to do, tip-wise, on how to deal with their reduced level of carbon dioxide, how to try to raise it up, because they're all different tricks that a biofeedback psychologist would use.
Interesting. If people are like engaging in meditation or something like that, would that help?
So I don't know the answer.
Yeah.
What they have to do is hook themselves up to the capnograph, see where their exhaled carbon dioxide is. If it's low, then yes, they should try that. But I mean, the basic thing that you have to do to raise your exhaled carbon dioxide is to breathe less deeply. So if you
Interesting.
clog your ears, you don't want to hear yourself breathe. If you and so I tell patients, put wax in your ears. If you hear yourself breathing, take a more shallow breath. So there are apps out there that give you 1, 2, 3, 4. 1 in, 2 no breathe, 3 out, 4 no breathe. So you can adjust so that you don't take a full deep breath in and a full deep breath out. And that helps reduce the depth of your breath, which allows your exhaled carbon dioxide to go up.
Interesting.
And that's the goal, Court. The goal is to get the exhaled carbon dioxide to a normal range.
What percentage of patients, do you have an idea what percentage of patients have this problem?
So I published on this. I don't remember the number. I did a paper on ME/CFS with my CDC colleagues about 3 years ago. And what we found is supine overbreathing, orthostatic overbreathing, orthostatic tachycardia, and then both. I call orthostatic overbreathing. So wait, orthostatic tachycardia is known colloquially as POTS, postural orthostatic tachycardia syndrome. So Julian Stewart, a brilliant pediatric cardiologist, and I named orthostatic overbreathing as POSH, postural orthostatic syndrome of hyperventilation. These are people who only hyperventilate during the gravitational stress. There are some who hyperventilate when they're just lying flat. And there is an overlap between the POTS and the POSH. Now, in our long COVID CFS paper, I think a quarter of them hyperventilated. In our ME/CFS paper, I think fewer hyperventilated, but then a bunch had POSH and POTS. I can look, Court, but you'd have to stop me when I stop the tape, and I can go look it up.
I will. Well, I will. I'll look it up and I'll put it in the blog.
So that was the 2 papers are the paper I did with Donna Mancini a couple of years ago, where she did stress testing and she reported dysfunctional breathing and hyperventilation. And we're working on an extension of that right now as we speak. And then the paper I did with, what's her name? Dr. Lynn at the CDC, Dr. Beth Unger at the CDC. So if you put Natelson and Unger into PubMed, it'll pop up.
Yeah. Thank you. Can I ask you, how did you get Donna Mancini interested in this? All of a sudden she popped up. She's very interested in exercise physiology. And
she's a heart failure doctor. And she's famous. And she, heart failure patients overbreathe. And she did a study years ago to help heart failure patients who were overbreathing strengthen their breathing muscles so they did better. How did I get her? Well, when I came to Mount Sinai, I knew about her and her interests in exercise physiology. And I knew there was something, and I wanted to work with someone to look at this question of exercise ability and PEM. And she and I wrote a grant together and it got funded. We've got another half a year to go. So any ME/CFS patients or sedentary controls, we want you in New York City.
There you go. It's a big city.
But
hopefully you can get enough people.
Well, if they come for 50 miles, and again, we can help them with a hotel the night of the study, that'd be great. So you can help us try to recruit people.
Absolutely.
And
Uh,
one thing I want to mention, since I am talking to you, is we are looking for a junior scientist to help us understand these breathing patterns and what's causing them. You were asking, we don't know what causes this odd breathing or the hyperventilation. So one of the things you can put in your blog is that we are hunting for a junior scientist to join us who knows about breathing.
got it. Got it. Very good. Very good. How is the hunt going in general? Are people interested, or have you
Oh,
just
you mean
started?
in the study?
No,
In
the hunt for another researcher. The reason I ask is that um, Jared Younger, I talked to him, I don't know, a year or so ago, and he was really having trouble recruiting postdocs.
Yeah, it's
Um,
hard.
yeah, he said he used to be able to, and he said it wasn't just him, it wasn't just MECFS, it was people were just having trouble finding postdocs.
Yeah, we are
Yeah,
too. Yeah,
yeah,
we are
yeah.
too. Court, I got to get off the phone now. Can I get back? And is this okay to stop now? I mean, we
Sure,
could keep
sure.
going for another hour, but I'm running out of steam. Uh,
Yeah,
so, so I'll be back to you when we want to talk about our VNS study. It'll be soon, but I don't want to do. And we talked about a lot of things today, so the VNS would have been diluted. Next time we'll talk about VNS. Okay.
yes. So that's just a that's just a something people can look forward to. We'll be talking about vagus nerve stimulation, something that Dr.
Yep.
Nielsen has had great interest in for a long time. He's one of the few researchers in this field who are actively looking at it. And so he has a study coming up, but we can't say anything about it yet because he is not ready uh, to get it going, but it won't be long.
No,
Uh,
it'll be about a court, I would say a month, 6 weeks from now. And I'll be back on your doorstep telling you about it so you can tell your bloggers about it. Okay.
great, great. Very
Thanks for
good.
doing this. Bye, Court.
Thank you very much.
Bye now.
Okay. Bye. Got it. Shoot. Okay. Um, So you